Welcome everyone. Thanks for joining us for today's webinar, The Role of Platelets in Type 2 Diabetes and the THEMIS trial. My name is Megan Shelley and I'll be your host today. This webinar is the fifth in the 2019 series of educational webinars presented by AADE in association with AstraZeneca-US Medical Affairs, Cardiovascular and Metabolic Diseases Division. This webinar is educational in nature and contains no promotional or product information. There is no continuing education credit for this webinar and handouts will not be distributed. If you would like to ask a question during the presentation, you can type it into the Q&A box on your screen at any time, and we will answer as many questions as possible during the Q&A session at the end. So I'd like to introduce Dr. Curtis Triplett, who will be our moderator today and helping along with the presentation and the Q&A. Curtis is a certified diabetes educator and associate professor at the University of Texas Health Science Center at San Antonio. So now I will turn it over to Curtis.
Well, thank you very much, Megan. Certainly want to welcome everyone to today's webinar. You know, we have such an interesting history here, so we've been going through systematically for different ways to decrease the cardiometabolic renal risk in our type 2 diabetes population. And today in our webinar, we're going to go over the role of platelets in patients with type 2 diabetes and the abnormal physiology of the platelet in this patient group. And we're going to discuss how this abnormal physiology relates to the overall cardiovascular risk in patients with type 2 diabetes. And then, of course, we're going to go over some of the currently approved treatments and how to reduce that risk and balance that with the risk of abnormal outcomes such as bleeds, as well as some more recent data. And we're really lucky today to have as our presenter Dr. Nani Bala, who's the Executive Director and Head of Cardiovascular Biopharmaceuticals Medical at AstraZeneca. It's now my pleasure to turn it over to Dr. Bala to begin.
Thank you, Curtis. Thank you very much. It's a pleasure to preside over this webinar today. So what we'll do is, as Curtis mentioned, go over a little bit on the role of platelets and then go over some of the recent data that's out in a trial. And just recognizing that the trial that I'll be discussing right now, those products do not have approval for use, but this is, again, hot off the press type of data. But I think, one of the things that I want to start off with is knowing that, we all accept the fact of ischemic heart disease in our patients with diabetes. We all recognize that this risk exists. Our patients exhibit it, but we don't really fundamentally discuss the physiology of the offender, so to speak, the platelets in these patients and how they actually go ahead and contribute to that risk or actually heighten that risk in patients with diabetes. So hopefully by the end of this talk, next slide, you should be able to understand the risk and burden of coronary artery disease in patients with type 2 diabetes and the current unmet need in this arena. Review the current management strategies for the treatment of CAD and type 2 diabetes. And then, as I said, explore the role of platelets and select mechanisms for why there is platelet resistance in patients who have diabetes. And then discuss the step-up therapy that has been investigated recently in the THEMIS study, albeit not yet approved as a treatment in these patients. Next slide, please. Next. So if you really look at the epidemiology and where we are today in patients with diabetes and the overall epidemiology and prevalence, you'll see that about 30 million Americans are living with diabetes, and 90 to 95% of patients with diabetes have type 2 diabetes. And then if you really think about pre-diabetes in the folks that are over the age of 18, that adds another 84 million patients. Now what's interesting is on the right, you see what's called a Markov model. And what this is a dynamic model of how the risk and prevalence change over time. So if you were just going to drop a line at 2020, that would hit about 30 million on this graph. So the reason I bring this up is that we're almost in 2020, but frankly, if I had shown you this graph 9 months ago, 2020 would still be at 30 million. But the point I'm trying to make is that we've already unfortunately beaten the Markov model as we come into 2020, because we're already at that 30 million mark well before 2020. Now, there is an incremental decrease in the diagnosis of type 2 diabetes that's been occurring over the last year or so. We'll see where all that goes. but nonetheless, this is a worrisome concern for all of us who are managing patients on a daily basis. Next slide. So, as I said, a growing healthcare concern worldwide. We do know that type 2 diabetes is strongly associated with microvascular and macrovascular complications. I think we're all familiar with that. And that 3 out of 5 adults with type 2 diabetes have at least one diabetes-related complication. This could include heart attack, stroke, just the presence of coronary atherosclerosis and heart disease, heart failure, kidney disease, eye disease, and foot problems that unfortunately can lead to loss of limb with amputations. And these foot problems can be multifactorial. They can be vascular in nature, they can be neuropathic, which then lead to vascular issues, or a combination thereof. And we know that overall diabetes is associated with increased risk of cardiovascular events, and there is a twofold increase in the risk of cardiovascular events in patients who have diabetes relative to patients without. And ischemic heart disease is the most common cause of vascular death in patients with diabetes. And it is important to recognize that when you're treating patients with diabetes, and again, all of you are familiar with this, so this is a multi-pronged approach. This is not one size fits all. It's not a magic bullet for everything. We need to really be taking all these things into account when we are treating our patients. Next slide. So this is just giving you a sense of the high risk of cardiovascular events and giving you a sense of vascular causes of death versus non-vascular causes of death in patients with diabetes. And you can see that ischemic heart disease overall is the leading cause, and certainly the leading cause of vascular death in patients with diabetes. And this is U.S. data. Next slide. This is data from another registry called the REACH registry, and what they did over here was looking at patients with diabetes in primary care practices. And there are 3 tiers on this graph. You can see 3 different curves. So the bottom curve is patients who have diabetes and have risk factors only. Then the middle curve is a diabetes population that has known atherothrombosis, meaning they have known atherosclerosis, they have ischemic heart disease, but have not necessarily had an ischemic event, meaning they have not had a heart attack or a stroke from their ischemic disease. And then the top curve is patients who have had atherosclerosis, but also have had an ischemic event, either a peripheral arterial disease event or a stroke or a heart attack. And it makes physiologic sense when you look at the 3 curves that as you stack one on top of the other, the risk of events, CV death, heart attack, or stroke, increase over a 3 to 4 year period of time. And what we're going to do towards the end of this talk is really concentrate on that middle curve of patients who have atherothrombosis but have not had a heart attack in the past. And on the right on the table, you can just see the overall relative risks and the hazard ratios, and you can see that it really doesn't matter whether we're talking about cardiovascular death, heart attack, or stroke. They're all quite increased in these patients. Next slide. So what about the overall risk when you're talking about diabetes by itself versus someone who has had a prior heart attack? What is the risk of events down the road? This is a registry data from Sweden, and what it shows you is that over a 3-year period, the patients with diabetes who've not had a prior stroke or heart attack actually have a similar risk as someone who has had a prior heart attack with an event rate of 13% in that 3-year period. Now you can see that the bottom curve, which is that curve with patients with diabetes and no prior stroke or heart attack, starts off a little bit sluggish, but by the end of 3 years, it catches up. Now there's a lot of debate about does having type 2 diabetes, is it actually a heart attack equivalent? And that data was submitted first about almost 12, 13 years ago. It was then debated because there were a lot of other data sets that suggested that maybe this was not true. What I would submit to you that regardless of the heart attack fact, what we should take home is the fact that having diabetes is certainly a risk equivalent of having had coronary atherosclerosis. We can debate about the event part, but as far as having had the disease part should not be debatable anymore in 2019 going into 2020. Next slide. This is data close to home. This is looking at DCR, which is the Diabetes Collaborative Registry data. This is a registry that is organized by the American College of Cardiology. And again, outpatient practices that follow patients with diabetes. So it's a mix of cardiologists, primary care physicians, and endocrinologists. And we're looking at the cumulative incidence, again, of stroke or all-cause death or heart attack in our patients who are older. So this is Medicare data set. And you can again see it's a linear line. And I think that's the other thing I want you all to pay attention to. All the lines I'm going to show you are pretty much straight up. They don't plateau. They don't seem to come down. They don't seem to just, taper off. This risk is continuous over time in these patients and hits about 17 to 18% in this patient group at about 3 years with a mean follow-up of about 1.5 years. Next slide. Well, what about the younger patient group? So this is a similar data set that I just showed you, but now in a commercial population. So these are patients from the Optum data set, which is primarily a commercially insured data set. And when you look over here, you again see that when you look at the same types of rates in patients who have had coronary atherosclerosis but have not had a heart attack or stroke, that the risk is about 11.5 to 12%. And here the follow-up is about the same that we saw before. It's about a median follow-up of about 3 years in this population. Next slide. So what about the cost? I've shown you the risk data. Well, what about cost? And you can see that, whether it's CAD, CVD, hypoglycemia, complications, renal failure, that if you look at the CAD-related costs, they are tremendous in this patient population, particularly if you look at inpatient costs, even if you look at emergency department costs, office visit costs, ancillary costs go higher for renal insufficiency because a lot of the dialysis supplies come up in the ancillary costs, and then the pharmacy costs are higher in patients with overall cerebrovascular disease because of, again, stroke care demands more cost as an outpatient. But inpatient costs are very much driven by the coronary atherosclerosis part of the disease set. Next slide. Well, what about the therapies for these patients? Next slide. So remember that everything starts with non-pharmacologic treatment. We'll end this talk talking about pharmacologic treatment, but we can never forget the importance of non-pharmacologic therapies in these patients. And all of you as educators and being on the front lines of educating patients, yes, we need medications and yes, we use medications, but never, never underestimate your reach with these patients when it comes to talking about non-pharmacologic measures. So diet is important. Going back, please. And really talking about the Mediterranean diet, DASH diet, saturated trans fat intake decrease, increasing plant phenols and cereals, looking at N3 fatty acids, viscous fiber. All of these are important. Obviously, caloric restriction and excessive alcohol consumption, all of those are important things to discuss with your patient when it comes to non-pharmacologic interventions. Next slide. Well, what about exercise? Again, I'm preaching to the choir here, I'm sure, that reducing excess body weight, increasing physical activity as much as 30 to 40 minutes a day goes a long way in this patient group and should be encouraged in all of our patients who can be out and active and do something physical for 30 to 40 minutes a day. Next slide. And then the pharmacologic therapies, and we'll talk a little bit more about that as we go forward. Next. So here is the puzzle, so to speak, and when you're looking at patients who have established coronary artery disease, lifestyle management still remains an important part. The other way that we manage these patients is with revascularization, and that usually means patients who are symptomatic and have coronary disease that can be fixed with either a stent or with a bypass operation. Recognize that these are adjunct treatments. These are treatments that are done to relieve symptoms in many of our patients, particularly if they have not had a prior heart attack or stroke. So these are just patients who are symptomatic from the disease. And they're also used to hopefully get our patients to be physically active again. So revascularization carries multiple rationales within itself, and recognize that a patient who's being very limited from physical activity because of symptoms, if you revascularize them and you improve their symptoms, they may be able to get to a higher level of physical activity, and that's always helpful in future risk management in these patients. And then pharmacologic therapies like antiplatelet therapies, which we'll talk about. Blood pressure lowering, extremely important, can never undermine the issue of glucose lowering in these patients and lipid lowering in these patients. Next slide. And if you look at the primary prevention guideline recommendations, we've again talked about the lifestyle management, a tailored nutrition plan in these patients, plan to improve physical activity, glycemic control, achieving ideal body weight as close to possible, and improving other cardiovascular risk factors. Glycemic control, we know about metformin. Obviously, a lot of data occurring now in other areas such as SGLT2 inhibitors and GLP-1 agonists, and trying to figure out, how these drugs fit in, and recognize that at least the European guidelines now have given physicians for these drugs potentially as first-line agents if metformin is not on the board, if you have patients who have increased cardiovascular risk. And then antiplatelet therapy, recognize that aspirin may be considered for patients who have type 2 diabetes, who have not had a cardiovascular event, but who are at high risk for cardiovascular events. And you need to have a discussion about the benefits of this therapy versus the increased risk of bleeding. And this last part is very important. I'm going to show you some trial data on aspirin, which will kind of speak to these two, this conundrum and this balance of risk from bleeding standpoint versus the benefit on the ischemic standpoint. Next slide. So here is the first of these, the three studies. This is the ASCEND trial. This was out of Europe, primarily done in the UK. And it looked at the use of aspirin in patients who had established coronary disease and cardiovascular risk, but had not had a prior event. So they had not had either revascularization of their coronary artery, or did not had a prior heart attack or a stroke. And what you saw in this group, but nonetheless they were felt to be at increased risk for having events. Now what you see here is that aspirin actually does better than the placebo group on the left graph, in the sense that what you find is that there is a 1.1% absolute risk reduction, and there's a significant p-value of 0.01. However, if we flip to right side, where you see a forest plot, and basically what forest plots are telling you is which treatment was better given a particular measure. So was aspirin better or was placebo better? So if you look at intracranial hemorrhage, you'll see that that box, that square, is on the placebo side. That the overall population actually did better not being on aspirin, though there were some patients that did better by being on aspirin. And this is because that horizontal line crosses the vertical line towards the aspirin is better side. And that's pretty much how you interpret forest plots. If you then look at any major bleed, the fourth one down, well, what you see is that that entire box and the horizontal line are on the right side, where placebo was actually better. And then if you look at any major bleed, that big diamond, which is pretty much, think of it as a sum of everything above it, is also on the right side of that vertical line, and placebo better side. And this is the conundrum of that statement that I made earlier about balancing the ischemic risk, the risk of having a heart attack or a stroke in these patients, versus increasing bleeding in these patients. And you can see that the bleeding hazard ratio was 1.29 or 1.3. So this is why that statement talks about having a very honest discussion and really understanding how much of an increased risk are these patients at before you subject them to the risk of aspirin and the bleeding. Next slide. This is the ARRIVE data set. ARRIVE was done in the US primarily, but then it also included some other countries. And this was looking at the efficacy and safety of aspirin at patients, again, at moderate risk of having cardiovascular disease. Now, this trial basically showed that it was a wash. There was no difference between the aspirin and the placebo group. I will say the study had a lot of problems. There were a lot of patients lost to follow-up. There was a lot of missing data. And in the end, there was really no answer from this study to say, do you give aspirin or not? So if we take ASCEND, which showed that little imbalance that I talked about, and we take ARIVE, which really didn't give an answer, we're really now in a place where we think, okay, aspirin as primary prevention in patients with established cardiovascular disease but no event might be in a gray zone. Next slide. This is the Esprit study, which looked particularly at the elderly population, and it showed that, again, there was no benefit, and if anything, you increased bleeding significantly in the elderly patient. And if you might remember, after ARIVE came out and ASCEND came out, there was a lot of news media, Wall Street Journal, New York Times, they all carried the story, and I know that a lot of folks were questioning whether they should be on aspirin or not. There was a lot of misconception. People who unfortunately had had heart attacks, patients who had actually had established coronary disease and had revascularization done with either bypass or stents were suddenly questioning and stopping their aspirin. And that was a real misconception because those are not the patients that were being addressed by these trials. And in the end, the recommendations are for patients who have not had a cardiovascular event or revascularization. So, and particularly in the elderly, the balance becomes even more precarious, and one has to be careful about prescribing aspirin if they've not had a prior revascularization or a heart attack or a stroke. Next slide. So this now leads us to what happens to the established patients with cardiovascular disease. And there's, as I said, general agreement that lifelong low-dose aspirin following a cardiovascular event or a history of atherosclerotic disease that has undergone revascularization is very reasonable. Now, what about dual antiplatelet therapy, which means combining aspirin with a P2Y12 inhibitor? Well, currently the guidelines state that it is reasonable only in patients who've had a heart attack for a year and then maybe beyond, depending on patient type. And we'll talk a little bit about newer data with the combination. But again, as I said earlier, that combination thus far is not approved, but it is new data to think about. What about blood pressure lowering? We obviously know that that's extremely important, and the targets are different in patients with diabetes. They're lower when we start, and they're lower in what we shoot for once we start treating. The same goes for statin treatment in patients with cardiovascular risk. The thresholds are lower to start, and the thresholds are lower as far as treatment guidelines and goals are concerned in these patients, and we should be cognizant of that when having our conversations. Other therapies that are also important, ACE inhibitors and ARBs are pretty much a mainstay of therapy to reduce cardiovascular events in patients with type 2 diabetes who have established cardiovascular disease, and certainly beta blockers should be continued for at least 2 years in patients who have had a prior heart attack, longer in patients who had a prior heart attack and have decreased left ventricular function, they should be continued longer. And then any treatment with anti-hyperglycemics is obviously recommended and should be followed closely based on multiple risk assessments, including hemoglobin A1C, but also the cardiovascular risk, particularly in the arena of SGLT2 inhibitors and GLP-1 agonists. Next slide. So where are we when it comes to antiplatelets in type 2 diabetes and CAD? Next slide. So when we think about type 2 diabetes and cardiovascular disease, we need to think about the fact that there are three main pathways or three main pillars where disease exists. One is endothelial dysfunction. And what this simply means is the dysfunction of the lining of the blood vessels. Believe it or not, the lining of your blood vessels is a massively important functioning organ. It secretes multiple things all through the day that keep the blood from clotting, that allow the blood vessels to dilate, constrict. There are a lot of factors that are produced by this lining that pretty much modulate the activity of how blood vessels behave under different situations. So this is an important part, and when this system goes awry, problems happen. Inflammation is another big part. Inflammation can occur independent of atherosclerosis, but it can also occur as a part of atherosclerosis, and again impact endothelial function and other pathways in the blood vessels. And then high platelet turnover and reactivity. So the platelets are your clotting factor. This is what makes the blood clot, along with a lot of other clotting factors that are secreted as well from the liver. And platelets kind of bring all this together to form a plug that causes clots. Now, when you're bleeding, this is a good thing. But when you have endothelial dysfunction, inflammation, and plaque that starts to break apart and the clot starts to happen, well, that unfortunately leads to heart attacks and strokes and other issues, and actually growth of plaques. And that is a mechanism that can be hopefully hindered by using antiplatelets and other treatments. Next slide. I'm not going to go into this mechanism. You have this slide, and if you're really bored one day, you can go ahead and look at all the details of this. But the reason I bring this up is that this is a complex phenomenon, and that's all I really want to bring across here today, is that when it comes to platelets and their interaction in patients with diabetes, this isn't something so simple and straightforward. When patients have hyperglycemia with diabetes, that affects how platelets behave. It affects the receptors on platelets. It affects how these platelets interact with other platelets and the blood vessel wall. When you have patients who are resistant to insulin action, there are issues that occur with endothelial function, with secretion of some of those things that I was talking about, where blood vessels don't behave like they should under normal circumstances. They actually behave abnormally, and as a result can create issues. Same thing goes with other metabolic conditions that come part and parcel of diabetes, such as cholesterol abnormalities, obesity, and inflammation. And there are various other similar abnormalities that occur at the level of the platelet interacting with the blood vessel wall lining and blood circulation that creates the platelets to get pretty much upset, angry, not happy, starting to do stuff that we don't want them to do, resulting in clot formation, increased atherosclerosis, plaque growth, et cetera, et cetera. Next slide. And this is pretty much what happens to the platelet life, so to speak, when a plaque ruptures. When a plaque, we all start forming plaques by the age of 12 and 13 in the U.S. So guys, gals, nobody's, immune to this. We all start forming this, and we are destined to grow plaques over time. And if you look at what the platelets do, once the plaque starts to rupture, they get activated and they start to adhere. They become sticky and they start to adhere to that abnormal area where the plaque has ruptured. Once they start to become activated by sticking to the plaque, they start to send out signals to attract other platelets, and then basically this becomes a platelet party, and everybody starts to come together. And before you know it, you're going on to a crisis where you start to occlude the blood vessel and occlude blood flow, which then leads to symptoms, which could be symptoms of a stroke, could be symptoms of a heart attack, and unfortunately the process then starts to become out of control and leads to damage, either damage in the brain tissue or damage in heart muscle. And all of these plaques are really part of what we call vulnerable plaques. And really what we have to start thinking about our patients with diabetes is that given these characteristics, these are vulnerable patients, not just vulnerable plaques in these patients. Next slide. And this is just the various pathways that get activated when the platelet gets activated, and these are attacked by different drugs. So for example, you have receptors that get activated that can be attacked by things that attack thrombin, direct thrombin inhibitors, or intravenous medications that we use emergently or urgently when patients have heart attacks. You have ADP receptors that start to get activated, and those are what are attacked by P2Y12 inhibitors. We'll talk about one of those in a moment. and then you have thromboxane pathways that are affected by agents such as aspirin. But unfortunately, these pathways are complex when thromboxane is activated, and as a result, aspirin by itself is not usually sufficient, and a lot of these patients are resistant to aspirin in its usual form. And then you have other receptors, glycoprotein receptors, and 2B3A is a receptor that can be attacked, usually by intravenous medications, and sometimes we will use therapy against this urgently in the setting of a heart attack or revascularization. Next slide. And this is just kind of going through what happens when a P2Y12 inhibitor is activated. So when you have ADP activation and use a P2Y12 inhibitor, once you inhibit P2Y12, you can start to see decreased intracellular signaling, and platelets live on intracellular signaling. Everything that happens on the surface basically gets transmitted to its innards, so to speak, and basically you start to get major activation of processes from the inside of the platelet. And remember, this is a cellular component that doesn't have a nucleus. Okay, we are very used to thinking of cell elements that have nucleus, and the nucleus is the brain of what's happening. Platelets don't have a nucleus, but they are still incredibly active because of all these signaling pathways that take place in their innards. Next slide. And when you look at the platelet, again, as I showed you this, talked about before, this shows it to you visually. You can see that as the resting platelet starts to come in contact with an abnormal area in the plaque, which is ruptured, you start to get platelet adhesion. You can then start to see how the platelet starts to get activated and starts to grow all these limbs. And as it grows these limbs, it attracts other platelets, attracts blood cells. Fibrinogen, which is one of those clotting factors produced by the liver, gets entrapped in the platelet. That gets activated to fibrin, and before you know it, you start to form this platelet party and fibrin thrombin party, which ends up as a platelet clot, which then results in that occlusion that we talked about. Next slide. So let's now talk about a P2Y12 inhibitor, ticagrelor, and some recent data on patients. Just again, recognize that this data is fresh, was just presented in August of this year, and ticagrelor right now is not approved for use in these patients in this particular venue of patients who have established cardiovascular disease but have not had an event. That still remains off-label for the particular agent. Next slide. So, we talked a lot about the mortality and morbidity in patients with diabetes who have established cardiovascular disease. We talked about the cardiovascular disease risk equivalent. We know that these patients exist in a prothrombotic state. We talked about the fact that their platelets, because of inflammation, because of endothelial dysfunction, because of obesity and hyperglycemia, there is just a milieu that these patients live in where platelets are revved up pretty much. And we know that ticagrelor has been shown to be superior to either clopidogrel or to aspirin in 2 other trials, either looking at acute heart attacks, which was in the Plato trial, and in Pegasus, which was looking at patients who had a prior heart attack. And we know that when you look at patients with diabetes, the data was particularly more robust. And the question was, well, what if you took patients who had diabetes and have established cardiovascular disease but have not had an event? If we add this drug to aspirin, will we see a benefit? Next slide. And what you see here is the design of the study. I'm not going to belabor the design, but to let you know that this is a trial of looking at ticagrelor 60 milligrams twice a day along with aspirin compared to aspirin alone. And what we looked at, and all these patients had to have had established cardiovascular disease, either by having had a stent or an angioplasty, or by having had a bypass surgery, or having had some imaging that showed they had a significant narrowing, but they could not have had a prior heart attack or stroke. And the primary efficacy endpoint was a composite of cardiovascular death, heart attack, or stroke, and the safety endpoint was major bleeding by a scale called the THEMIS scale. And what you will notice is that if you look at some of the baseline characteristics, the idea here is that about 80% of these patients had some sort of revascularization, either by a stent or angioplasty or by coronary artery bypass surgery, and they were all on pretty good therapy overall. Next slide. And this is the overall population, and then we looked at a particular group of patients who had undergone a PCI, which is percutaneous coronary intervention, which means that either had a stent or balloon angioplasty, and we will look at this group separately. And this was a predefined group because we were curious to know in this trial, depending on what the overall population showed, if there was a particular subgroup in the population that had a greater benefit or a greater net clinical benefit potentially. Next slide. So this is the overall result of the study. If you notice, the patients on ticagrelor at the end of 3 years, which is where we drew the endpoint. So even though the curves carry on beyond 3 years, please note that the predefined endpoint was at 3 years, and there was a 0.7% absolute risk reduction in this patient population, and a relative risk reduction of 10% with a p-value that was significant of 0.04. So there was an overall benefit in this patient population for cardiovascular death, MI, or stroke by adding ticagrelor to aspirin for efficacy. Next slide. However, what we also noted was that there was an increase in THEMIS major bleeding, and that hazard ratio was about twofold higher in the patients who received ticagrelor with aspirin, along with compared to aspirin alone, and that was at 2.3. And again, this was a significant p-value. And no matter how you slice the data from a major bleeding perspective, it was increased in the patients who had ticagrelor on top of aspirin, and the intracranial hemorrhage rates were also increased in that patient group. Next slide. So then the question became, well, what about a group where we thought that they could do better? So in the sense that we understand that in the overall group, yes, there's an efficacy benefit, but there's a risk of bleeding, and which is significant. So is there a group that we can optimize that benefit and risk? And that's where we looked at the PCI population, those patients who had undergone a prior PCI or a stent or balloon angioplasty. And this made up about 67% of the overall population. And you can see that the benefit here was greater. It was a risk reduction of 1.2% as opposed to the 0.7% I showed you before. And there was a 15% relative risk reduction, and the p-value was also significant in favor of the patients who went ticagrelor with aspirin compared to aspirin only. Next slide. And then when we looked at the overall outcomes compared to the patients overall, you can see that the patients who had a history of PCI, and again, I've kind of gone over the forest plots with you, but what you can see is in that compared to the patients with no history of PCI, the history of PCI group is entirely to the left side of the line, the vertical line, which gives it, which is on the side of the ticagrelor being better. And then if you looked at cardiovascular death, all-cause death, MI or stroke, there was a consistent benefit favoring the ticagrelor plus aspirin group versus the aspirin group if you'd had a prior PCI. Next slide. But bleeding was still increased, but to a lesser degree in this patient population. If you look at the overall THEMIS population, I've shown you that hazard ratio of 2.32. But if you look at the patients who had undergone PCI, it was actually down to the 2.03 range. So yes, there is definitely a risk-benefit here that is better than what we had seen in the overall population. And if you then looked at intracranial hemorrhage, it was actually a wash between those patients who got ticagrelor plus aspirin versus aspirin alone. That's the second row in the bottom part of that table. And if you look at fatal bleeding, it was again a wash between the group that got aspirin only versus the group that got ticagrelor plus aspirin. So what it tells us is that if we're trying to equalize the playing field a little bit in the patients who, from a bleeding perspective, with respect to fatal bleeding or intracranial hemorrhage, the PCI group seems to be where we can equalize that playing field to some degree. Next slide. And this is what we call a net clinical benefit, and there are multiple definitions of net clinical benefit. In this case, net clinical benefit basically means things that are really, really bad in the sense of intracranial hemorrhage, death, heart attack, stroke. So these are irreversible events and fatal bleeding. So frankly, if you die, if you bleed in the brain, if you have a major heart attack, if you have a stroke, if you die from bleeding, I can't reverse any of those events. So what you do is you basically say, okay, show me all the irreversible events in the treatment arm versus all the irreversible events in the placebo arm, which in this case is the aspirin-only arm, and let me see what that difference looks like. And you can see that that difference, again, favors ticagrelor with aspirin versus aspirin alone. So that is the key take-home here, is that when you look at the irreversible harm events, they are favored in the ticagrelor plus aspirin group versus the aspirin-only group. Next slide. So in conclusion, understand that patients who have CAD and type 2 diabetes are at increased risk of experiencing a cardiovascular event, regardless of whether or not they've had a prior MI or stroke, and recognizing that when it comes to utilization and cost, at least from the inpatient perspective, CAD is the costliest complication for patients with type 2 diabetes. Talk about platelet dysfunction. You have the slides to review to go into all the details you want to with all the references there. But in a nutshell, platelet dysfunction, including platelet hyperreactivity, is a key driver of thrombotic risk in patients with CAD and type 2 diabetes. Platelets are unhappy, they're revved up, and they don't enjoy being in that milieu, and they love forming clots in patients with type 2 diabetes. Current recommendations include, as we talked about, diet and activity as strong non-pharmacologic interventions in patients with type 2 diabetes, and then pharmacologic approaches in patients, which we are still developing to meet an unmet clinical need in these patients. THEMIS was a trial that looked at trying to increase the platelet inhibition by attacking a different pathway along with aspirin. So as I showed you, aspirin attacks the thromboxane pathway. The ticagrelor attacks the P2Y12 inhibitor ADP pathway, and trying to see if giving this synergistic double pathway inhibition, if there is some decrease in risk and how that carries over to the bleeding side. And as I showed you, in the overall population, there is definitely some benefit, but there's also an increased risk of major bleeding, and the net clinical benefit is not necessarily in favorable terms of treating these patients. However, in patients who've undergone a PCI, meaning a prior stent or balloon angioplasty in the coronary arteries, that yes, there may be a better net clinical benefit ratio, and if we were going to consider patients in the future, this would be a group that we could consider this therapy in, realizing again that currently the therapy remains not approved by the FDA. And I will end there, and we will take questions.
Great, thank you so much. So we are going to open it up for questions right now. So if you have a question that you'd like to ask, you can type it into the Q&A box on your screen. And we've already got a few questions in, so we can jump right in. So the first question I will direct to you, Dr. Bala, and it asks, how can we listening today assist in the risk conversation?
Yes, I think, all of you are on the front lines of managing patients with diabetes. And I think that a lot of times, you're faced with patients who will ask you questions about their treatments, and though the decisions will lie a lot of times with the cardiologist or the physician that may be taking care of those patients, I think the more knowledgeable you are about these aspects of care, the better equipped you are to at least have an initial conversation and guide them through that process. So I don't think that it's necessarily that you'll necessarily be involved in making that decision, but certainly understanding those questions better and guiding those patients better to that decision process will be helpful. Curtis, I'll have you chime in too. I mean, from your perspective, I know you are obviously seeing patients at UT. What are your thoughts on how folks can help?
Megan, could you repeat the question, because I just I missed it. so I apologize. Can you
Of
say it one more
course.
time?
So the person's asking how they can assist in the risk conversation with their patients.
Oh, okay. Well, I think what Dr. Bala is saying is completely on track with what we would say. You know, we certainly talk to them about the risk conversation, and it really goes to the fact that, you know, in type 2 diabetes or long-standing type 1, there's a higher risk of cardiovascular disease. And I think that we as educators and as providers need to kind of get on board with that and understand that there's no one therapy that we're going to recommend. We're going to talk about their risk now and what their future risk is and how we can minimize that. And I think we need to understand that it's multifactorial. We have many things over the last 5 webinars we've talked about to decrease cardiovascular risk, and we should use all of those and talk about all of those different things to our patients as potential therapies to decrease the risk of the thing that kills most of our patients with diabetes, whether it be type 1 or type 2, which is cardiovascular disease.
Thanks, Curtis.
Great, thank you both. Dr. Bala, is there a way to decrease the thrombotic risk in these patients within the management of their diabetes?
Yeah, that's a good question. It's actually a tough question. I think that, you know, we talk about the non-pharmacologic management, but those are standard modus operandi for all these patients, and we should be having those conversations, as Curtis talked about as well. I think that, you know, what's interesting is the THEMIS data that I showed you. I don't think it was in the baseline characteristics part, but their hemoglobin A1C was 7.1 in this study, which means they were pretty well controlled. And even with that control, you saw what those curves looked like in the placebo group. And what I didn't share also is that in that placebo group, that rate of events was actually very similar to the patients without diabetes in our trial that we had done in patients who had had a prior heart attack 1 to 3 years prior to their entry into the study. So what's interesting is that even with good control of hemoglobin A1C, you know, which we obviously have to pay attention to, and it's important, there was still this risk. So I think that it goes without saying that we have to manage all those things, the glycemic control, the non-pharmacologic management treatment, lifestyle, and diet and exercise. But even in a well-controlled group, you know, these things raise their ugly head, and we then have to really individualize where we add on other pharmacologic therapies to help these patients. But I think that's the conundrum, that even in a well-managed group, we see these issues.
Great, thank you. Dr. Bala, I'll direct this next question to you as well. And the person is asking if type 1 diabetes is also a part of this.
So it's interesting, right? Type 1 is more akin on the microvascular side. The macrovascular jury on type 1 is very interesting. It tends to occur much later in their lifetime, so to speak. And the question is, does that macrovascular cardiovascular disease, is that part of the diabetes part, or is the fact that, unfortunately, in the Western culture, we are all somewhat destined to have a high risk of cardiovascular events down the road? So there's this disconnect a little bit between microvascular and macrovascular in type 1 relative to type 2, where macrovascular is quite prominent because of their diabetes. So I would say to you, yes, it applies to type 1 as well, but the timeline is very different in type 1 than it might be in type 2 per se.
Great. Curtis, I'm going to direct this next question to you, and it's asking what comorbidities should one be concerned about that could further heighten the risk in the patients?
Well, I mean, I think that if we're talking, it depends on which risk we're talking about. If we're talking about cardiovascular disease, and I think we've covered those in the past, but we need to understand that, again, that we multifactorial treat our patients. So if we see they're obese, if we see that they have a history of cardiovascular disease, of course, that's the big one. If they smoke cigarettes, of course, if they have hypertension, they have dyslipidemia, all those things kind of go into your risk without a doubt. When we're talking about antiplatelet therapy, though, I think we start thinking about, well, what is the downside to antiplatelet therapy? And of course, that goes into more about the risk of bleeds. And so I think that, one of the reasons why the recommendation is no longer there for all people with diabetes to be put on antiplatelet therapy, aspirin, to begin with, and then to consider dual antiplatelet therapy in certain high-risk patients, is because of the fact of bleeds. So what they found is basically that the risk of reducing cardiovascular disease sometimes is outweighed by the risk of bleeding. And so some of those people that are higher risk of bleeding include people who are older, greater than 75, or at least, certainly a lot older, and in other certain high-risk populations. So I think if we just start there and start realizing that the reason why we balance it is because we want to make sure that we get the benefit without the risk. And I'd pass it over to Dr. Bala for more information, too.
Yeah, no, I agree, Curtis. I think that everything you've said is spot on. I think the only other risk factor that I would add is peripheral arterial disease, and I think smoking was a big one that you brought up. I will say that in practice, if you see folks who are unfortunately smoking, have diabetes, and have peripheral arterial disease, boy, that risk just escalates of cardiovascular events and issues, and you just need to be so diligent in guiding them to, you can prescribe all the medications in the world, but really getting them to think more about quitting smoking and talking about those things, and exercise becomes so important to those patients. I think you're spot on.
Great, thank you both. Dr. Bala, how do you reconcile the data from SGLT2 inhibitors and the data on antiplatelets?
Yes, I would say that, listen, obviously a lot of excitement, right, about SGLT2 inhibitors, GLP-1 agonists in cardiovascular disease, definitely a very big heart failure angle with dapagliflozin, for example. But I think what we have to consider, and frankly, I don't anticipate that we'll have data on this in any time soon, is that the mechanism of action is very different when we're looking at those drugs that SGLT2 inhibitors, other than obviously helping with glycemic control, are very much cardiovascular drugs when it comes to heart failure, when it comes to modulating that risk of hospitalization for heart failure, et cetera. And their mechanisms of action are multifactorial. But we don't know that they have an effect necessarily on the platelets. And certainly the drugs that we're talking about are more in the platelet arena. Now can I say to you, well, maybe they'll have a synergistic effect? I don't know the answer to that. We certainly, as I said, won't know data, and I don't think that anybody's going to be doing a study of combining these agents in the near future because it would just be a very large study and take a long time. So I think we will accumulate this data from the real world side probably over time. We'll see as patients come into treatment pathways with these drugs and with antiplatelets, what does this look like in the real world, and probably going to wait 2 or 3 years to get that data. So I would say that right now the hypothesis would be that they work through different mechanisms of action, and they may have additive or synergistic effects, but that still remains to be seen.
Great, thank you. Dr. Bala, I'll throw this next question to you as well, and it asks, how long patients need to be on BRILINTA?
So that's an interesting question. It all depends on why they were placed on BRILINTA in the first place. So if they've had so according to the guidelines, currently, if you've had a heart attack and you were started on BRILINTA for a heart attack, then the guidelines recommend that you stay on it for 12 months. There is a reassessment period that can occur at 6 months to assess bleeding risk for the patient. But if you can get them out to 12 months, that is definitely a recommendation. And then based on the risk of a predicted risk of future events versus bleeding, the recommendation is to continue beyond 1 year. And then after that 1 year period, it's pretty much a dealer's choice, so to speak. I think you have to really assess all the risks. And you can certainly continue out to 3 or 4 or 5 years. That's where we have the data so far. We don't have data out to 7 or 10 years, frankly. We have data in a mean time frame of 3 to 5 years. And then, beyond that, I think it just depends on how that patient is doing. But beyond that 1 year should be a risk assessment, but I would say to you that patients who have diabetes, who have kidney dysfunction, who have peripheral arterial disease, who have multivessel disease, who may have received a bypass, continuing longer than 1 year is probably more beneficial for those patients than someone who doesn't fit into that category.
Great, thanks. And I'll throw this next question to you. Maybe Curtis can chime in too, but it asks, can patients take both ASA and BRILINTA?
Yes, so they can, depends again on the treatment. So for example, right now, the guideline recommendations are for a combo of BRILINTA plus aspirin in patients who are receiving it for after a heart attack with a prior heart attack, whether it was just recent or more than a year ago, and there it's given with aspirin. There are some new data sets that have come out that are looking at BRILINTA by itself, but again, right now the drug is not approved for monotherapy, and as such, right now for your patients, other than it really is the cardiologist's decision based on some of the new data whether they decide to go to monotherapy with BRILINTA. But having said that, I think, from the perspective of the folks on this call, I would say that decision should be deferred to the person prescribing the BRILINTA in the first place, whether the aspirin can be dropped or not, because they're in the best situation to assess why the patient was started and where the patient is in that timeline to see if aspirin can be removed from their therapeutic.
Great, thank you. And to maybe quickly wrap it up, Curtis, would you mind sharing maybe a few key takeaways that would be applicable for the educators and the audience to apply in their clinical practice?
Absolutely. I think one of the things we as educators really can do is we've been talking about cardiovascular risk, but I think you might be surprised how many of these people coming in may not be taking their medicines or may not be taking the right medicines. Obviously, if they've had an MI or something like that, a lot of times they've had some follow-up, but there becomes this gray area where all of a sudden people are just continued on the therapy they've been continued on because that's what they're on. So, it's always good to kind of take a look at that, and if you, as an educator, are starting to see that the person has had some problems or that they're not taking, maybe they're a candidate for a proton pump inhibitor to decrease the risk of bleeding or things like that they're just not doing anymore, that's our job to kind of take a look at their risk, and if something major has changed, to make sure they get back to the right people. So I always see us as, the helper in the system, and the helper in the system is to be the patient's advocate and make sure that they get back to the right people. Maybe we're not the one changing therapy. I've always said that about educators. Maybe we're not the ones changing therapy, but identifying and getting them back to the right people to make those changes is really important as an educator, and I think that's where we come in here with antiplatelet therapies, to make sure, number one, they're not having any bleeding problems, and number two, to really make sure that they're taking the therapy that can decrease their risk. And antiplatelet therapy is a part of that for cardiovascular disease.
Wonderful, thank you. So we would like to thank Dr. Nani Bala and Dr. Curtis Triplett for being here today and presenting this important information, and we thank you all for attending today's webinar. This webinar was recorded and it will be posted on our website at the link you see on your screen within the next week or so, and it will only be up for about 60 days, so make sure you check it out. Thank you all. This concludes today's presentation.